It's always fun to see who's joining us today. So please feel free in the chat if you want to introduce yourself, say your name and where you're from. It's always nice to kind of see who's joining us from everywhere. With that, I just have a few announcements that I'd like to go through. One is just about, if you're not already a member of ADA, I encourage you to join. There's a lot of member benefits. You can see them on this slide here, but there's special interest groups where you can really network with other people. There's the standards of medical care, of course, which are updated every year, Diabetes Pro quarterly. So a great network, and it's great to see lots of people are putting in the chat where they're from. It looks like we got people from all over, from Florida, Missouri, Kentucky, New York, California. Yay, Ohio. That's where I'm from. So great to see everybody joining us there. I also just wanted to let you all know that there's a number of certificate programs, if you're not already aware. There is the Diabetes and Primary Certificate Program bundle, as well as Overcoming Therapeutic Inertia. And then there's also a Primary Care Practice Optimization bundle that includes both of the other certificates. So those are things, I think the links for these are going to be put into the chat. You can see the link on the slide here. And then also there's a link. I can see Danielle put the link in the chat. If you're interested in membership and you're not already a member, you can go ahead and sign up to be able to do that. Also, Time and Range really wants to hear from you. So I encourage you to join. If you're not already a member, join the Time and Range online collaborative. This is a place to share best practices, request input if you've got a question, a patient situation you want to hear from other people about, a place to share articles, new literature coming out. So definitely encourage you to check that out. And the link for that is also posted in the chat. Now, for our program today, we have a really, really exciting agenda happening today. I am so excited because we are going to be hearing from two experts, and we're going to be hearing from the U.S. perspective and also the European perspective, and then we should have plenty of time for Q&A. And our objectives today are we want to increase knowledge of time and range. We want to identify current best practices utilized in treating diabetes during pregnancy. And then we want to recognize the benefits of CGM use during pregnancy. And please take advantage of the Q&A feature. And we'll be, at the end, we should have plenty of time to have discussion and go through that Q&A. Now, with that, I am very excited to go ahead and introduce today's first speaker. She brings a very unique perspective to our discussion, and this is Dr. Florence Brown. And she is the co-director of the Jocelyn and Beth Israel Deaconess Medical Center Diabetes and Pregnancy Program. She participated in the 2008 American Diabetes Association Pre-Existing Diabetes and Pregnancy Guidelines Committee, and also was an editor and co-author of Managing Pre-Existing Diabetes and Pregnancy, Technical Reviews and Consensus Recommendations. She's also currently a member of ADA's Professional Practice Committee, and I've had the huge pleasure to serve with her on that committee the last 2 years. And her interest in the management of gestational diabetes and pre-existing diabetes in pregnancy, where that's her main interest, where she tries to make sense of the many controversies. And a focus of her research is on factors that affect fetal growth and large birth weight infants and women with type 1 diabetes. So we are very excited to have Dr. Brown, who's going to present on time in range. How is CGM data presented? And with that said, I will turn it over to Dr. Brown.
Diana, thank you for that introduction, and it's a pleasure to be here to talk to you about time and range. How is CGM data presented? Well, we start with the ambulatory glucose profile. The AGP is a licensed standardized glucose report created by the International Diabetes Center. AGP provides a standard set of information and graphs relating to diabetes management and is only one part of understanding glucose patterns. It includes the dates of the data, usually 14 days, the percent that the time of the CGM that is active, which should be greater than 70%, average glucose, glycemic variability, which is in this case a coefficient of variation, which is defined as standard deviation divided by the average glucose, the time and range data, and a graphic representation of glycemic patterns and a summary of daily records. So the first patient is a 32-year-old gravida 2 para 1 with type 1 diabetes of 20 years duration, presenting for a follow-up outpatient visit at 34 weeks. She manages her diabetes with multiple daily injections, monitors glucose with a meter and CGM. She has a high school education and is living with her fiance. Her preconception BMI is 21. Her CGM has been downloaded in reviews. In this case, her targets are set at 65 to 140 milligrams per deciliter or 3.6 to 7.8 millimoles per liter. We use the 65 instead of the 63 just because there's an easy drop down to get to the 65 that goes by 5 milligrams per deciliter on the report. So this is her AGP page. Her dates are in the upper right-hand corner. The time that is active is 98.5%. Her average glucose is 90 milligrams per deciliter or 5 millimoles per liter. Her standard deviation is 13 milligrams per deciliter or 0.7 millimoles per liter. And her time in range is 98%. Her time above range is 0%. And her time below range, less than 65, in this case, 2.0%. And she has had no low blood glucoses in the level 2 low of less than 54 milligrams per deciliter. And her glycemic patterns are graphed below. And we can see that the targeted range is 65 to 140. That's the hashed targeted range. And her median glucose is represented by the orange bar, the orange curve, and the blue bar is her interquartile ranges. And we can see that the pattern is rather flat and within all the targeted range. And below that, we can see the daily representation of the summary of her glucose data. And that glucose data, the daily report is seen here in a larger representation. And she has very flat, well-controlled glucose levels throughout, maybe some dips on 1 or 2 days, but those are short-lived and treated easily. And this is the overlay of the last 7 days of those daily glucose reports superimposed on each other. Again, achieving nice low blood glucoses over the course of the night and having acceptable rises post meals and very well controlled without many low blood glucoses seen here. And this is her best day. Her best day, her average glucose was 91 milligrams per deciliter, 5.06 millimoles per liter, and she's in target 100% of the time. And this is her data throughout her pregnancy. So we have her average, her standard deviation, time in range, time above range, time below range, and time less than 54, all mapped out from the beginning of her pregnancy where her average was 140 to the end of her pregnancy when her average was 90 milligrams per deciliter. And you can see the millimoles per liter there too, and the standard deviation. We can see that despite the decrease in her average glucose and her standard deviation, her time below and the improvement in her time in range from 79.9% to the 98%, we can see that her time below range and her time less than 54 were really acceptable and negligible. And this is, if you like to graph things, this is what her whole pregnancy looks like. With glucose on the y-axis on the left and percentage on the right y-axis, and then the weeks of her pregnancy the x-axis, and the blue bars representing the average glucose decreasing over time, time in range in the green curve increasing, time above range just briefly elevated and coming right down to an excellent level, and really a flat minimal time below range and time less than 54 through her whole pregnancy. So how did she do this? Well, she also monitored blood glucoses with a meter. She tested before and after meals, and also sometimes at bedtime and in the middle of the night. And she kept a detailed record of her glucose levels and wrote down her basal insulins, which she was taking twice a day, and her mealtime insulin based on insulin to carb ratios. And she adjusted her insulin doses based on the patterns that she was seeing. And she also pre-bolused 10 to 15 minutes before her meals. She did not give extra correction boluses, and she waited several days before she saw a pattern before adjusting her insulin doses. And she managed her diet by consuming healthy carbohydrates that were low glycemic index, high fiber, unprocessed carbohydrates that she paired with proteins and healthy fats. And she checked in with her care team regularly and often for each of the decisions that she was making to adjust her insulin doses. So the international consensus on time in range recommends certain clinical targets for continuous glucose monitoring data. And what is time in range and what are the targets? Well, time in range is the percentage of time that a person spends in the target glucose range. And this is different from non-pregnant adults to pregnant women with type 1 diabetes. And the time in range for non-pregnant adults is 70 to 180, but for pregnant women, it's 63 to 140, and that's 3.5 to 7.8 millimoles per liter. The time above range is 180 to 250, 10.1 to 13.9 millimoles per liter. And for pregnancy greater than 140 is considered above target, 140 milligrams per deciliter, and that would be 7.8 millimoles per liter. There is no time above 250 considered for pregnancy. Time below range for non-pregnant adults is 64 to 69 milligrams per deciliter, 3.0 to 3.8 millimoles per liter. But for women who are pregnant, it's 54 to 62 milligrams per deciliter, 3.0 to 3.4 millimoles per liter. And both groups, the time below range that is considered level 2 or urgent low, less than 54 milligrams per deciliter, is less than 3.0 millimoles per liter. And what are the time in range goals? Well, we expect time in range in pregnancy and in non-pregnant adults to be greater than 70%. Level 1 time above range, or time just standard time above range for pregnancy should be less than 25%. There is no acceptable time above range greater than 250 in pregnancy. Time below range, it should be less than 4%. And level 2 time below range which is less than 54 milligrams per deciliter, less than 3.0 milligrams per deciliter, should be less than 1%. And the international consensus of time in range acknowledges that these metrics are defined for patients with type 1 diabetes, and that they are not recommended for women with gestational diabetes or pregnancy complicated by type 2 diabetes because there is inadequate data. Most of this data comes from type 1 diabetes. So patient 2 is a 24-year-old gravida 2 para-0 with type 1 diabetes, 12 years duration, presenting for an outpatient visit at 6 and 2/7 weeks. She reports that prior to learning that she was pregnant, she really wasn't bolusing for her meals. She was not very careful about her dietary intake. She has some high school education, hopes to take the test for the graduate equivalency degree, and lives with her husband. Her BMI is 33. She manages diabetes with an insulin pump and monitors glucose levels with her CGM. Her recent A1C was 12%. or 108 millimoles per mole. Her CGM is downloaded and reviewed. Her time and range targets are set at 70 to 180 milligrams per deciliter, 3.9 to 10.0 millimoles per liter at her first visit, but they were changed to 65 to 140 or 65 to 140 milligrams per deciliter or 3.5 to 7.8 millimoles per liter at her subsequent visits. And this is the representation of the AGP page for her first visit. She's wearing, her sensor time is 94.4%. Her average glucose is 269 milligrams per deciliter, 14.9 millimoles per liter. She has a wide standard deviation of 85 milligrams per deciliter, 4.7 millimoles per liter. And her time in range is 18.6%. And notably, her time spent above 250 milligrams per deciliter is 57.1%. And we can see that graphically here. And then this is the overlay of her most recent 7 days of blood glucoses, showing this wide variation in her blood glucoses from high to low, actually never going below the threshold here. And then this is her daily, showing that many blood glucoses above 300. But her best day is the day before she came to clinic, before she saw a provider for her diabetes and pregnancy. She made significant changes when she learned she was pregnant. She started bolusing for her meals, and she started eating healthier carbohydrate. And her average glucose decreased to 156 milligrams per deciliter on this day, which is 8.7 millimoles per liter. And at her next visit a week later, her average glucose had decreased to 189 milligrams per deciliter for that 2-week period. And that's 10.5 millimoles per liter. And she still has a low time in range of 23%. But it's definitely moving in the right direction. And then the next several weeks later, her average glucose now is 126 milligrams per deciliter, and her time in range is up to 66.7%. And this was with ongoing titration of her insulin doses and her insulin pump settings. So this is the most recent visit where we see that despite her average of 126 milligrams per deciliter, we still see a rise in her blood glucoses on this overlay overnight and a spike after the first meal, indicating that we need to adjust her overnight basal rates and increase them and strengthen her insulin to carb ratios. And her data throughout her pregnancy is here with a remarkable decrease in her average glucose over this time period, improvement in the standard deviation, the improvement in the time in range and time above range decreasing, and her time above 250 going from more than 50% down to 0.6%. And most notably, that despite that improvement and lowering of her blood glucoses, her time below range is acceptable. Less than 4% for the time below range, and for the time less than 54, it should be less than 1%, all acceptable. And this is a plot of her data here showing the improvement in her glucose levels on the blue bars, and the percentages of time in range in green bars, time above range decreasing with time, and despite that, the very flat and low time below range and time less than 54. Patient 3 is a 37-year-old gravida 2, para 1 with type 1 diabetes, 17 years duration. She has a master's degree and lives with her husband. Her preconception BMI is 26. She manages her diabetes with insulin pump with predict before low suspend. She monitors her glucose with a continuous glucose monitor. Her CGM targets are 65 to 140 or 3.5 to 7.8 millimoles per liter. And she had a recent hemoglobin A1C of 4.6% or 27 millimoles per liter. And here is her AGP page. Her CGM is active 97.6% of the time over this approximately 14-day period. Her average glucose is 98. Her standard deviation is 37. And her time in range is 71%. Her time above range is 13.1%. And so that looks pretty good. However, her time below range is almost 16%, and that should be less than 4%. And her time spent less than 54 milligrams per deciliter is 8.2%. And we can see from the overview page that the times where she's having low blood sugars over the course of these 14 days, what are the patterns of low glucose levels? When are they occurring? Well, they're occurring multiple times during the day, seen by the red bars below 65 milligrams per deciliter here, multiple times during the day. And this is the overlay that shows each of the daily patterns superimposed on each other. We can see patterns of high, low, high, low, high, low, frequent and prolonged amounts of time spent below the target range multiple times during the day, and really not responding to these low blood glucoses quickly. And so we need to look at her pump to see why this is happening. And we can see a very reactive approach to her diabetes self-management. And her blood glucose increases above the target range. She turns on her temporary basal being more than twice what her usual basal is, runs it, lets herself have low blood sugar. Fortunately, her predict before low pump suspend turns her off to mitigate some of this. Her blood glucoses climb in the morning, probably due to a missed bolus for her breakfast. She corrects with a bolus, and then about an hour and a half later, she gives another bolus, plus she's turned on her temporary basal. Needless to say, she drops low again. She gives a bolus for her lunch meal around noontime. Doesn't trust that she gave the right bolus, so gives phantom carbs of 20 additional grams. Her blood sugars stay quite low, and fortunately, again, her pump is turning off her basal. And then she spikes up again later in the afternoon, probably because she didn't adequately cover her meal initially, and then realizes that she didn't do this and gives some extra carbs and some phantom carbs, and then turns on her temporary basal again. And this is a pattern that just is repeating itself constantly. It's, again, very reactive pattern. So this is her data throughout pregnancy. Average glucoses are reasonable. Standard deviation is reasonable. Her time in range is acceptable. Her time above range is good, but her time below range is consistently high. And it's very difficult for her providers, me in particular, to get her to change this pattern that she's doing. Her time below range is dangerously high. And here is her weeks of pregnancy that we've been following her, and her glucose levels, again, acceptable, time in range acceptable, but very high curves for her time below range and time less than 54 milligrams per deciliter. So I'd like to just move on to accuracy of CGM, not just in pregnancy, but just in general. The best meters are more accurate than CGMs, and that's because they're expected to be so. The International Organization for Standardization expects meter accuracy to be plus or minus 15 milligrams per deciliter for blood glucose is less than or equal to 100 milligrams per deciliter, and for blood glucose is greater than 100 milligrams per deciliter for more than 95% of the measurements. CGM accuracy is expected to be plus or minus 20 milligrams per deciliter for glucoses less than or equal to 100 milligrams per deciliter and greater than 100 milligrams per deciliter for more than 90% of the measurements. There is another way of measuring accuracy of the device or CGM device or meter, and that's called the mean absolute relative difference, or the MARD score. The CGM or meter that is being evaluated is A, and the reference measurement of high accuracy is B, and the MARD score is reported as percentage of comparison of A minus B divided by B times 100%. And so the best top meters, top 7 meters, have achieved MARD scores of 5.6 to 8.2%. And yet CGMs are lagging behind in accuracy, 8.7 to 9.8% here. So with that, I will turn it back to Diana, who will introduce Anku Mehta.
Great. Well, thank you so much. That was fantastic. I loved the cases and the real world application of it. I want to remind everyone, if you have questions, please put them in the Q&A. It looks like a lot of people have already, which is great. And we're going to get to all the questions at the end. So now I have the privilege of introducing our second speaker, Dr. Anku Mehta, who will be providing her perspective of the educator's role in addressing time and range in the clinic. And Dr. Mehta joined West Hertfordshire Hospital in 2018, where she is a consultant obstetrician and gynecologist with a special interest in obstetric medicine. She is the lead for endocrine disorders in pregnancy and runs joint antenatal clinics with endocrine consultants for women with diabetes, thyroid disorders, and other endocrine disorders in pregnancy. She also runs obstetric medicine clinics for women with medical disorders in pregnancy. She provides preconceptional advice to women with medical disorders, and she is a member of the National Expert Reference Group for Gestational Diabetes in the UK. And she has a keen interest in quality improvement and has introduced remote blood pressure and glucose monitoring in pregnant women in her trust. And she's currently leading on a national quality improvement for improving inpatient management of pregnant women with type 1 diabetes. And she's the principal investigator for the PARIT-2 trial, and also, which is actually a multi-center randomized controlled trial of revealed versus concealed repeat placental growth factor based testing in women presenting with suspected preeclampsia. So wow, that's a lot. Very impressive. We're very excited to have Dr. Mehta, and I'm going to go ahead and turn it over to her.
Thank you so much, Diana, and thank you, Dr. Brown, for an excellent presentation. And thank you, ADA, for giving me this opportunity. So I'll essentially be talking from an obstetrician's perspective. I know Dr. Brown gave you a brilliant endocrine's perspective from this point. So I will be talking about our national pregnancy and diabetes audit data from the UK. I'll be talking about the evidence which we have used for CGM in pregnancy, particularly the lessons learned from the concept trial, the national implementation of CGM in pregnancy in the UK, and the impact on real world outcomes. So this was a national audit which was started in 2013 in the UK, in which we look at all women with any type of pre-existing diabetes across England and Wales, which started in 2013. This is the latest data of nearly 10,000 women with type 1 and type 2 diabetes between 2019 and 2020. And this is the first time when type 2 has sort of overtaken type 1. We now have more women with type 2 diabetes in the UK than type 1. And if we compare it to our data from 2003, there's been a 100% increase in women with type 2 diabetes, and the number of women with type 1 diabetes is also on the increase, and gestational diabetes as well is increasing far more, which we are all aware. the first question that this audit wants to ask is that were women adequately prepared for pregnancy? And we can see, unfortunately, that since we had this audit in 2014 to now, unfortunately, we haven't seen an improvement, and only 1 in 8 women entered pregnancy well prepared. And why does that really matter? Because if these women don't enter pregnancy well prepared, they've got a higher risk of having congenital anomalies, stillbirths, neonatal deaths, and that could be higher than 10%. Whereas if they enter pregnancy well planned, their risks of serious complications fall closer to that of women without diabetes. So if you can see the HbA1c, ideally, according to the NICE guidance in the UK, we don't want women to be pregnant if they've got an HbA1c of 86 or over. But unfortunately, time and again, we see women who've had unplanned pregnancies and they end up with more complications. The higher the HbA1c, the higher the chances of anomalies, perinatal deaths. And we looked at this forest chart, which you can see, where we looked at what were the factors which were affected most at higher HbA1c levels. Those were younger women, higher BMIs, deprivation, and a longer standing type 1 diabetes. So essentially, we wanted to prioritize these women to have continuous glucose monitoring. And then if we compare our outcomes from 2014 to now, are we getting better? Unfortunately not. We still have a lot of preterm babies, large babies, and we're not really improving, but we are sort of, the complications are increasing. Women are becoming more complex. They have more comorbidities. They are older, they're bigger and more complex. How can we minimize these complications? It is well aware that women who have an HbA1c of 48 or more, which is 6.5%, as is used in the US, are in the 3rd trimester, they have a higher rate of preterm, large babies, as well as neonatal admission. So having a good control would have better outcomes. We also looked at adjusting the data for diabetes type, duration, ethnicity, deprivation, and BMI across the country, because we had data from the whole of England and Wales. And unfortunately, we found that there was very minimal variation between the clinics. So clearly, there was something different that we all needed to do if we wanted a different outcome. And that is when NICE guideline with an update of CGM came in December 2020. The question that was there in the evidence review was like, what is the most effective method of glucose monitoring to improve maternal and infant outcomes? So we're looking at both good outcomes as well as cost-effective outcomes in the NHS. So we looked at continuous glucose monitoring, flash glucose monitoring, which is also known as intermittent scanned CGM, and capillary blood glucose, which is self-monitoring of finger sticks, SMBG. So this is the evidence. I'm not going to go in too much detail. Overall, we looked at 2 RCTs and 1 retrospective cohort study, of which the concept trial was the most powerful study. Concept trial was a multi-center international randomized controlled trial, which looked at women who had real-time CGM versus women who used fingerstick alone in managing their type 1 diabetes. So if you can see, the primary outcome that they were looking was the change in HbA1c. There was a small but a significant difference in these women from baseline to 34 weeks. Women with CGM had a lower HbA1c. The percentage of CGM time in range, which is 3.5 to 7.8, which is an internationally accepted standard, as Dr. Prong pointed out. CGM mums spend an extra 100 minutes in glucose target range. And I'll just, from an obstetrician's point of view, I would just stress on that a bit more, saying that it doesn't sound a lot more. It says just 100 minutes, but I think if we've been looking after mums with diabetes for a while now, and actually they are very, very complex pregnancies. They are long-standing diseases. They want some sense of normalcy. You know, even their childhood, you know, they wouldn't. It's not as easy as going to a birthday party and having the cake as and when you want. So they've come from. They will also have mental health issues, anxiety. They sometimes tend to blame themselves as well. When we tell them, you know, there's a lot of information overload as well. We tell them that, you know, you've got type 1 diabetes. These are the risks to your baby, and they sometimes carry that guilt as well. So I think it's very, very important that we form a rapport with the woman and understand where they're coming from. And their targets are a lot tighter when they're pregnant than when they are not pregnant. And often they are the most motivated when they're pregnant. And it's not unusual to see someone who enters pregnancy quite poorly and then literally turns around because she's so motivated. So it is all very good that we have so much data, we've got so much information and education to empower them, but it's really, really important that we establish that rapport that whatever they are doing is good and every little helps. So I think that's really, really important. And when we use real time, if you look at the outcomes, you can see that the large for gestation age babies, hypoglycemia, neonatal admissions were all less in women who used CGM. And if you look at the numbers needed to treat, it is quite impressive that you just need to treat 6 women to have 1 less large for gestation age baby and 1 neonatal admission. So that's a good economic as well as a good outcome. This is observation cohort study, which was from Sweden, which was also looked at, but given that it was an observational study, it was not a very powerful study, so we could not really base our evidence significantly off it. But you can see they compared women who had real-time CGM versus intermittently scanned CGM, and there wasn't a whole lot of difference in their time in range. They're pretty similar. There wasn't a lot of difference between 10 and 30 weeks anyways. But there was, what was found was that women who used intermittent scanned CGM, they had a higher time below range across pregnancy. And hence those women would need more SMBG, would need more finger prick testing as well compared to a real-time CGM, where we don't recommend them doing checking their sugars. And I think that's slightly different to what the practice in US is. I'm just going to skip this. So eventually NICE clinical committee, they looked at these evidence and they looked at the quality of life, neonatal stay, postnatal ward stay, and overall it was decided that it is actually quite cost effective to introduce a real-time CGM because it offsets the cost of staying in a neonatal intensive care unit, and the postnatal ward was offsetted by the cost of the equipment. And from December 2020, across the NHS, all women with type 1 diabetes are offered real-time CGM to improve neonatal outcomes. We enter our data to the national data set as always, and we want to ensure a fair and equitable access because these are the women who need it the most. And there has been a lot of support, training for healthcare professionals as well as patients, education for optimal use, because it's all very good that we have so much data out there, but what we do with the data is far more important than actually having the data. Again, this is looking at the clinic to clinic variation, so not a huge variation, so clearly new interventions were needed, and that's when the NICE guidance came up. So we offer it to all moms with type 1, and we also offer it to moms who are on insulin therapy but do not have type 1 but have a severe hypoglycemia or have unstable blood glucose levels, or have eating disorders, mental health issues, or are needle phobic. Whoever you feel you can apply the funding for. Dr. Brown has already taken us through this, so I'm not going to spend a lot of time on this slide, but I'll just, especially from the obstetricians in the audience who don't see this on a very daily basis, and I believe the number of women with diabetes is on the rise, and I think everybody should be aware your time in range is your 3.5 to 7.8 or 63 to 140 milligram per deciliter. You want to achieve more than 70%, and just to be aware that 1% is 15 minutes. So this was the data from the concept trial, and CGM, in CGM mums whose babies had large gestational babies and neonatal hypoglycemia versus those mums with CGM who did not have these two adverse outcomes. The time in range difference was as low as 5%. You can see from the absolute difference here. So actually, just that extra 75 minutes a day of having blood glucose between 3.5 to 7.8, actually, it will improve outcomes, and it will reduce your chances of having a large baby and the other issues that come along with it, and neonatal hypoglycemia, admission to the neonatal intensive care unit. So do we still need to measure HbA1c? Definitely. We very much use it as a predictor of pregnancy outcome at the beginning as well as in the third trimester. And it's a very good assessor of obstetric and neonatal risk, understanding that the value can be marred or skewed by anemia, the hemodilution in pregnancy, and other hematological disorders. For CGM, the best predictors were time in range, time above range, mean glucose, which we look at, and that, like Dr. Brown showed in her slides, is very much for the woman to sort of guide her diet, her insulin therapy on a day-to-day basis, be mindful of what she's doing and looking at her patterns and working on her data. And time in range can also predict preterm, large gestational and neonatal hypoglycemia and neonatal admissions from 12 weeks onwards. So we are quite aware that when we say we should enter pregnancy well in these women, it's sort of, you've sort of set the ballpark very early on in pregnancy, and we want them to be very well controlled right from the first trimester onwards to have a good outcome. So CGM is a different way of thinking about diet and insulin. When women look at their patterns, they are able to then recognize, I won't go in depth because Dr. Brown has already taken us through it, but the pattern recognition, understanding simple things like, what did I eat, and can I do something different? Do I need to, if I exercise this much, do my sugars come down? I probably need to give my insulin, earlier than I did. So all those peaks and troughs, they would reflect on that. This is just from the concept trial, the UK participants, if you look at the diet that they were eating, so 50% of their diet was non-recommended sources. So if they are looking at their data and they're looking at their sugars and what they're eating, patients are a bit more mindful, and then they can act on that data. This is just a little bit of top tips, which are there in the Diabetes UK website as well. Timing of meantime bolus, earlier in pregnancy, at least 20 minutes, and later on in pregnancy, about 45 minutes later. Attention to the quality of meals, like I said, and these women would then use the alarm. So what is different than checking your sugars, if they were checking a finger prick, is that they have to actually check. So if they don't check, they don't know. So with the real time, it actually alarms you, it shows you the trends, and you can avoid hypos, avoid your sugars going too high, and proactively, without getting scared, increase your insulin. And again, the aim would be to get the trajectory time in range as soon as possible in pregnancy to get it on target. This is our latest CGM feedback. The woman in the picture, she was our first patient with a real-time CGM. And actually the women love it. And they say it's life-changing. These are some of the best bloods that I've ever had. One less stress and preventing serious nocturnal hypos in a busy job. It alerts to your phone so that they don't have to pay attention. And actually it forces you to pay attention and to act on the data. So take-home messages are use of real-time CGM, as shown from the concept trial, does improve maternal glucose levels and improves neonatal outcomes. Currently, we are offering that to all women with type 1 diabetes in the UK and other women who are insulin dependent as and when needed. And we use CGM rather than HbA1c and SMBG to guide the diet and insulin therapy. And I would say that 70% time in range, yes, that's what we want, but every 5% improves the outcome. And in second trimester, it just helps women in intensifying because their requirements go up because of the insulin resistance and the increased need. And women with type 2 diabetes, they are quite complex, and we know now with the data that we have, they have actually got a higher rate of stillbirth, looking at the last 2 years data. So we should be considering them. Obviously, we don't have that much data and evidence to support that, but it does help. Thank you.
Thanks. That was awesome. I'm impressed with how much material you're able to get through, both of you. So that's wonderful because we have time now for Q&A. So as a reminder to everyone, if you haven't, you please put your questions in the Q&A, and we're going to go ahead and get started. I saw a couple questions that actually came through about, can CGM replace BGM? If a woman's wearing CGM in pregnancy, does she still need to check pre-meal or postprandial readings? And so I'll throw this question to Dr. Brown to start with.
So I will just say the concept trial evaluated BGM plus CGM versus BGM. So we don't actually have a head-to-head of CGM alone versus BGM alone. And so we don't have that data. It would be interesting to have that data. My feeling about it is that that blood glucose monitoring offers a distinct time point before and 1 hour after each meal for patients to look, write down their readings, and then be able to look for patterns. The CGMs may not be quite as accurate as the blood glucose meters also. So I am still encouraging my patients to test their blood glucoses before and 1 hour after each meals. We have particular glucose targets for blood glucose monitoring for fasting and 1 hour after meals that people can look at those patterns.
Great, thank you. And kind of continuing on with that question, someone said they're really having trouble getting, even when they recommend for patients to check, that they actually adhere to checking. I'm just curious, Dr. Mehta, like your perspective on this question or what you guys do in the UK.
Yeah, so I think our practice is slightly different to the practice in US, and Dr. Brown is absolutely spot on in saying that when concept trial, they actually had the Medtronic RealTime CGM, which was A, not licensed for use in pregnancy, and B, had to be calibrated. So you had to use your finger sticks. Whereas in the UK, when we say CGM, even in the NICE guidance, when they say CGM, they actually refer to real-time CGM. What we offer to women here is Dexcom G6, which is CE marked for use in pregnancy in European Union, as well as factory calibrated. So we do not encourage women. We don't tell them to routinely check their sugars with that. And I believe, and I think that, to me, I think is the biggest sort of quality of life or, sort of improvement. And it is a very, very, very intense pregnancy. And yes, we all want 100% brilliant sugars, but I think that taking away that, whatever, if they don't need to keep checking. And obviously we do tell them to check. And often these women have lived with diabetes, pretty much all their lives with type 1 diabetes. So they very well know that if their sugars are, they don't, sort of match their symptoms, then they will check. But it's not something that we proactively ask them to do, which is to be different to that. If they are on intermittent scanned CGM, then yes, which we know that the hypos tend to be more. This is my understanding. Again, I'm an obstetrician, I'm not an endocrinologist, but in the UK, real-time CGM, we do not actively encourage women to do the finger sticks.
Thanks so much for providing that perspective. Dr. Mehta, I have an additional question for you that came through about how do you engage primary care in preparing patients for pregnancy, and how do you engage your patient? And then continuing, the same person also asked, how do you engage the midwifery team and trainees in the process of learning CGM and managing these patients?
Yeah, I think that's a brilliant question because So how things are in the UK is that type 1 diabetes tends to be with the hospital settings, type 2 tends to be with the community, with the GPs. So obviously a lot of preconceptional counseling lies with the GPs. We do teaching sessions for the GPs, and a lot of these women will come through us. We run teaching sessions and preconception counseling clinics as well. But I think a lot of responsibility does lie with the GPs for type 2s. With the type 1s, as soon as they're adolescents, you are taught, and, we take it through them. But unfortunately, like I said, when you look at our data, 1 in 8 of our women are not entering pregnancy well. There are a lot of structured education programs out there which are free, but unfortunately the uptake is very poor. So clearly we need to do more, definitely, but we engage as much as we can with the GPs. And as far as the obstetric and midwifery side is concerned, given that the number of women with diabetes is sort of exponentially increasing, especially the gestational diabetes. At least in our unit, I can speak pretty much, there'd be no day in an obstetric unit where you will not have a woman with diabetes in pregnancy. But it's not something that the midwives or obstetric trainees are taught to a very high level. And if you are in a setting where you have a lot of support from the endocrine team 24/7, it's quite easy. If you don't, then it can be quite challenging to manage these women. So it's really important. So we run courses for our midwives, we run courses for our trainees, and we are hoping to drive it a bit more, because given that the number of women with diabetes in pregnancy is increasing, and I think that is something that should be looked at nationally as well. Yeah.
Thank you. We have another good question that came through. I'm going to throw this one to Dr. Brown. It's about how there's a lag time with CGM. And so let's say you have a patient who's not doing finger sticks. So you just have the CGM data to look at. If you're trying to focus on like 1 hour or 2 hour postprandial, do you look at 2 hours and 20 minutes or 1 hour and 20 minutes because you want to take into account that lag time?
Oh, that's a great question. Yeah, I think you have to add 20 minutes on because of the lag time. So again, it's a little hard with the CGM to know which data point are you going to choose, since it's continuous. I think it's confusing for patients to figure that out. We definitely want the fasting blood glucoses to be under 100, probably somewhere like 70 to 95. Some people say 70 to 99 milligrams per deciliter, and I don't know what that is in millimoles per liter off the top of my head. But and then the 1 hour blood glucoses to be, say, 100 to 140. And so which on the curve, which do you pick? And generally it should be the peak postprandial. Whenever the peak postprandial is the glucose level that you want to choose.
Yeah, I totally agree. I tend to focus on what that peak is and trying to see if it's, stays under 140 or not. Great. We have a lot of questions about the use of CGM in gestational diabetes or pre-existing type 2 diabetes. So wondering if we can hear, we can start, Dr. Brown, we can start with you again, your experience with that and your thoughts on using it in those populations.
I think it's overkill for patients with gestational diabetes. I think it's CGM would be too much information. People with type 1 diabetes need it for hypoglycemia unawareness. I think it wouldn't be a great use of resources for patients with gestational diabetes, just confuse them. And we're looking at their blood glucoses again, fasting and 1 hour or 2 hours postprandial. That's what you need. You don't need the in-between times so much. For type 2 diabetes, it depends. There's some patients with type 2 diabetes that are on 4 shots of insulin a day. They may have some hypoglycemia as well, and so they may benefit from a CGM. But if your patient with type 2 diabetes is, mild, similar to somebody with like gestational diabetes, they may not need that. But it's so based really on your impression of that patient and the seriousness of their diabetes.
Thanks. Dr. Mehta, curious on your thoughts, or even if you can get it for these types of patients in the UK.
So I totally agree with Dr. Brown. Again, there's limited evidence for both type 2 and GDM, so we don't have the evidence for it. But I would just say that yes, we have used for several of our type 2s because I do believe that like I said, type 2s are looked after in community. Some of them, when they come to see you in the clinic, because we do the clinics with the endocrine consultants, we sit together. Often we do feel that some women are mislabeled as type 2 and are not type 2. That is one thing. And if they are insulin dependent and other issues like say mental health issues, they've got, they're not really checking and this is sort of the best bet, then yes, we go with it. So, you'll pick and choose your patients, not all, but the ones we have picked and choose, yes, we have been able to get the funding, and it definitely makes a difference to their blood sugars.
Yeah, I agree with the points. We unfortunately don't have really, evidence in gestational diabetes. We're actually going to be doing a study here at Cleveland Clinic trying to look at that because we really need to build evidence to determine, is it useful? Is it worth the cost or not? Would it be, information overload, or would it be helpful? So yeah, we need to accrue more evidence.
Yeah.
Go ahead.
Yeah, sorry. No, like you said, I think that's quite interesting because just one point to say with GDM and type 2, I sometimes feel that we should be treating them as a continuum as well, because last year when we changed our guidance of doing, how we, obviously screening GDM is like, the whole world does it differently, and, what your values for GTT are. So we moved to HbA1c instead of GTT in COVID, purely because of, having so many women come into the hospital to do the test, and we picked up so many type 2s, at booking, with the high HbA1c. So I just feel that, I'm not giving an answer here, but I just feel that, sometimes the women you pick up with gestation diabetes, pre-existing diabetes. So I think there's no right answer to it, but yes, I feel that it's a continuum, the type 2 and the GDMs, yeah.
So I know we're running short on time, but this one should be a quicker question. People want to know, where should you place the CGM sensor in pregnancy? Like, what would be the optimal sites?
Well, I think the G6 is approved for the abdomen, but off-label, people use their arms, and I think they're fairly accurate, but it is off-label. The Freestyle Libre 2, the intermittently scanning device, is approved for use on the arms.
Yeah, and I've only ever seen them on the arms, pregnant women. Yeah.
I think, abdomen, for obvious reasons, is sometimes preferable to avoid. And it's interesting because even though, it's true, Dexcom G6 is approved for the abdomen, there was a study that showed in pregnancy that the accuracy was actually better in the back of the upper arms. Yeah. So those are things. And sometimes we consider other off-label sites like the legs, upper buttocks, get kind of creative with that. Well, I want to thank our speakers today. Just absolutely incredible. I'm so grateful for your all of your information. And just so everyone knows, the recording will be available. So if you missed anything, we will have that. So you can watch that later. You can share it with your friends and everything. Just a couple closing remarks that I want to leave everyone with. So the ADA scientific sessions is happening. It will be happening this June in New Orleans, but we understand that COVID is still happening. So there is a virtual option. So if you can't make it in person, that is okay. We hope to see you either in person or virtually. And also just want to remind everyone, for any additional resources and to register for Time and Range next webinar, you can visit the website, which you should see posted in the chat. It's the same one we showed you in the beginning. And then also, it's right there. And then upon exiting the webinar, you will be asked to complete a brief survey. So please, we'd be grateful if you can provide us with feedback on today's program. And then I want to thank everyone for your time. We look forward to connecting with you again on the next Time and Range webinar, which you can see here will be March 23rd, 4 p.m. Eastern. And thanks. Have a great evening, everybody.